to reassume their nucleotide analog therapy, the magnitude of reduction in quantitative HBs antigen levels, and the proportion of exaggerated hepatitis flares. And the data are quite convincing, I must say. You see here that patients who were just stopped for the nuke treatment had very rarely an HBs antigen loss at year 3. This is shown in the blue column. 3% had actually an HBs antigen loss. However, those patients who received an interferon treatment after stopping the nuke achieved a functional cure at a rate of 14.3%, which in fact achieved statistical significance. So if you look also for the secondary endpoint HBs antigen loss and undetectable HBV DNA at year 3, which is in the bottom line, you see that almost 10% achieved this endpoint, the secondary endpoint, while only 1 out of 68 patients achieved this endpoint by just restoring the nucleotide treatment. The other secondary endpoints are shown here. So if you look for the number of patients who were inactive HBV carriers 3 years after stopping the treatment, there were roughly 50% who remained inactive carriers, and this rate was somewhat, but not statistically significant, higher in those who received the interferon treatment, with roughly 59%. The number of patients who had to restart treatment with a nucleoside analog was lower in those who received interferon, with 28.4%. And it was in patients who just had the nucleotide withdrawn, the resumption of nucleotide treatment was at the rate of 35%, which does also not achieve statistical significance, but showed a clear trend towards favoring the interferon treatment. Quite impressive also the number of patients who had exaggerated hepatitis flares, something which is very worrisome if you stop the nucleotide treatment. So in patients who had only stopped the nucleotide treatment, up to 35%, or a number of 35 patients, 36 altogether, had an exaggerated hepatitis flare, while this rate was much lower in those patients who received subsequent interferon therapy after withdrawal of the nuke. Number of events here, 12, which is just a third of exaggerated hepatitis flares compared to the control group who just got the nucleotide analog withdrawn. So overall, quite impressive results. And of course, this is the efficacy, and you have to compare also the safety side. And here one must say that, of course, patients receiving a 4 months treatment with interferon have slightly more reports of adverse events, which are apparently linked to the interferon treatment. Typical side effects of pegylated interferon, no new side effects occurred. However, the number of serious side effects was comparable in both groups. One patient died. This patient only had a nucleotide withdrawal treatment without subsequent interferon treatment. So at least these adverse events which were linked to the study treatment was higher in the interferon-treated patients, but this is, of course, clearly understandable due to the side effect profile of interferon. So I'd like to repeat the question you just had in the introduction. In the NUC B study of chronic hepatitis B treatment after nucleotide withdrawal compared with placebo, adjuvant pegylated interferon therapy for 4 months was associated with a number of exaggerated hepatitis flares, a higher rate of functional cure, a higher resumption of nucleotide acid therapy, and a higher rate of treatment interruption due to adverse effects. Please vote. Can we see the results? Yeah, answer B is correct. There was definitely a significantly higher rate of functional cure, which was defined as HBs antigen loss. Adverse event profiles, at least the severe adverse event profile, was similar. The number of exaggerated flares and nucleotide therapy resumption were actually reduced numerically in the pegylated interferon-treated arm. So that's for hepatitis B. And I just remind all my colleagues that these data of HBs antigen loss have to be compared also with rates of HBs antigen loss in current experimental treatments, which are not yet approved for treatment, but we have seen a number of phase 2, phase 3 trials with various new treatment options. And I must say, even though it's a comparison across trial and no head-to-head comparison, I think that these nucleotide stopping treatment strategies are quite impressive, and even more impressive by an added interferon treatment. Let's move now to delta hepatitis. You are all familiar with the MUIR 301 study, which compared actually 2 doses of bulevirtide against no treatment and a delayed treatment of bulevirtide 10 milligrams. So the key point of this study was to compare 2 milligrams given on a daily basis subcutaneously versus 10 milligrams of subcutaneous bulevirtide treatment. And we still have very good safety data for bulevirtide. And you see in the MUIR 301, the overall treatment duration was 144 weeks, which refers to almost 3 years. And we have now seen in the EASL presentation the follow-up data another 100 weeks, so 2 years later after the end of therapy. So really data which look for the sustained response. And if you look in this table, you see on the left part CR, which refers to complete response, VR, which refers to virologic response, and the rate of ALT normalization and undetectable HDV RNA, the percentage which was sustained from the end of treatment in percent. If you just focus in the columns on the columns of follow-up week 96, which is the third column of each of the treatment groups, bulevirtide 2 milligrams, 10 milligrams, and delayed treatment, you see that the complete response was at 24% 2 years after the end of treatment, and that did not show any difference between the 2 milligrams and the 10 milligrams, and even the delayed treatment arm achieved very similar rates of complete response. The virologic response is also not different at the follow-up week 96 in the 2 doses of bulevirtide, as is the rate of ALT normalization. You may think, but it's not statistically significant, that the undetectable HDV-RN rate as a percentage of end of treatment response seemed to be a little bit higher in the low dose of bulevirtide than the higher dose, but I cannot imagine that this would hold up in a larger trial. Overall, the message is here that the 2 treatment doses in monotherapy are somewhat similar, and most important, that the 90% rate of sustained HDV RNA undetectability of treatment There was always a concern that HDV is going to relapse very early after stopping bulevirtide, but here these data really show that somebody who has achieved undetectability at the end of treatment is able, in most cases, to sustain this virologic response over at least 2 years and probably even longer. A small rate of HBs antigen loss in patients, 2 patients in the delayed arm, and one of each patient in the 2 other arms. This is really not meaningful. We would clearly look for higher HBs antigen rates, but the HDV RNA undetectability and the sustained undetectability is a great response from this follow-up data of the bulevirtide treatment. We have also an analysis here of the liver-related safety endpoints, and here it's worthwhile to mention that the clinical events are very similar across treatment groups and are typical for a population with hepatitis B, hepatitis D, Delta co-infection. Patients are typically very severely affected, have advanced liver cirrhosis, and therefore may suffer from complications of the underlying disease rather than the treatment. However, a concern is after stopping treatment, the possibility of ALT flares, but this does not seem to be a major difference between the 2 treatment arms, but there are substantial ALT flares possible, so therefore a very diligent surveillance after the end of treatment is mandatory in patients, and it argues very much to the European label by the EMEA, where actually we in Europe have the possibility to continue bulevirtide as long as a physician has the impression that the patient benefits. So stopping treatment may not always be a good opportunity, and some patients with a flare, we would probably, if the drug is available, have a resumption of bulevirtide treatment. Nevertheless, we have to take care when you stop treatment. Then we saw at EASL also a very interesting post-treatment analysis, a pooled analysis of the MUIR 204 and the MUIR 301 study, which basically compares the 2 doses of bulevirtide, the 2 and the 10 milligrams given on a daily basis subcutaneously. But most important, also the comparison whether you add pegylated interferon to each of the doses to treat hepatitis delta. And if you here look at the responses, you have actually 3 figures. On the left side, the end of treatment results. Then in the middle panel, the follow-up week 24, and on the right panel, the follow-up week 48 data. Then you have in the individual columns, in each of the 3 groups, the treatment of bulevirtide 10 milligram for 96 weeks, bulevirtide 10 milligrams for even longer periods of time, 144 weeks, and the response of bulevirtide 10 milligrams plus 180 microgram pegylated interferon at treatment week 96. And you clearly see in blue, that is the patient proportion with undetectable HDV RNA level, that the addition of pegylated interferon is clearly superior to the monotherapy of 10 milligram bulevirtide. 70% of patients were undetectable for HDV RNA at the end of therapy. If you then look in the middle column, you see that the addition of pegylated interferon also adds to a longer sustained virologic response. Almost half of the patients, 46%, remained undetectable for HDV RNA 24 weeks after the end of therapy. And this rate, very similar to the study I showed to you previously, is maintained over time. So 46% also remained HDV RNA negative at follow-up week 48, and we are optimistic even thereafter, but this has not been covered yet and not yet published. And it's a clear indication that the virologic response benefits from patients who can tolerate and who have added pegylated interferon treatment. So the key takeaway messages are summarized in this slide. In the NUC-B trial in e-antigen negative patients, the adjuvant pegylated interferon increased the rate of HBs antigen loss and reduced the number of exaggerated ALT flares after nucleotide withdrawal. This is really something which can be translated immediately into clinical practice if you have the experience in this respect. Second key takeaway is that bulevirtide for either 2 or 10 milligrams for 3 years leads to undetectable HDV RNA levels between 29 and 50% of chronic delta patients. And most important, that this response is maintained even 96 weeks off therapy in 90% of cases. The combination of pegylated interferon and bulevirtide 10 milligrams achieved the highest responses at the end of treatment and lower relapses during the follow-up period. So EASL 2024 was a kind of revival of pegylated interferon, both in the treatment of hepatitis B as in hepatitis B plus delta. Briefly, a quick look into optimizing HCV care. You know, we have excellent antiviral therapies available, and the London group looked into the impact of HCV elimination program on mortality. And they had a focus here in the group of disadvantaged groups, and they created a score which was abbreviated with IMD. And the higher the IMD score, the more patients had disabled characteristics. And the question was whether the IMD score adds to the mortality in patients who had achieved an SVR without cirrhosis. And it also looked on the mortality rate in a large number of patients which remained untreated. And they looked into the mortality rate with respect to this disability of these patients. I think for time reasons, we can skip here the methodology. Key is that there were no notable differences in the baseline characteristics. So on this slide, you show the results of this study. In the left panel, you see the mortality in non-cirrhotic patients who achieved an SVR were those who were untreated. In total, of course, the mortality is much higher, achieving 25 to 30% rate in untreated patients, while the mortality rate was exceedingly low in patients who were non-cirrhotic and achieved a sustained virologic response. If you then looked for the extent of disabilities of these patients, there was not much of an influence. Even in the most impaired patients, the delta was very similar between treated and successfully treated and untreated patients. However, in the right panel, you see the mortality in untreated populations from the most deprived population to the least deprived population. And you clearly see that over time, the mortality is mostly exaggerated and high in patients which were most deprived versus those who were least deprived. So we really have to focus on SVR rates, on treatment in all of our patients, but in particular to the high risk of mortality in the population of deprived HCV-infected people. A second study came from Spain, looking into an innovative strategy for re-engagement in care. So what they basically did was to look in the hospital system, hospital files, either electronically or manually, for patients who had ever been admitted to the hospital and were anti-HCV positive. And then they looked whether these patients still had a serum sample available in the central laboratory and checked those patients for HCV RNA. And thereby they were able to identify quite a high number of patients who were in fact not only anti-HCV positive, but remained viremic. And they were able, from the files, from the identification of the patients from the file, to relink those patients back to the hospital, starting them on treatment. And they were actually able to relink the care in those patients in 2/3, in 67%, and even able to have a very high access to care. 64% actually initiated treatment. And you know, the end is always, if somebody starts on treatment and remains reasonably compliant, you can correlate this with a very high sustained virologic response rate. So it's an interesting approach, really, to find yet untreated patients. And I think this is very important to achieve the WHO aims in our individual countries to eliminate hepatitis C on the long run. With that, I like to conclude and hand over to my colleague, Dr. Goel, who is going to discuss the EASL data on PBC. Thank you.
Great. Thank you so much. I will be reviewing the highlights of PBC management that were presented at EASL. It's a nice time for PBC, and it's great that there's so much that we can potentially review and discuss today. So the first abstract that I'll review evaluates predictive markers for early assessment of response to PBC treatment. This was a multi-center retrospective analysis that evaluated several markers for complete biochemical response in persons with PBC that were treated with UDCA at the appropriate weight-based dosing at 2 hepatology centers over a 25-year period. These patients had only PBC. We excluded patients that had overlap syndrome, prior UDCA therapy, or less than 18 months of therapy. There were 155 patients that were included in this analysis. And like most patients with PBC, the mean age was 57 years, most were female, and the follow-up period was approximately 10 years. Cirrhosis was identified at baseline in about 20% of patients. The findings of this study were quite interesting. So complete biochemical response at the end of follow-up. So remember that follow-up at the end of this study was close to a median of 10 years. So a complete biochemical response, normal alkaline phosphatase levels, was identified in 51 patients of the 155. At 12 months of treatment with UDCA, about 64% of patients had a complete biochemical response. So what factors predicted who would have a complete biochemical response at the end of follow-up? What the study evaluated was Toronto criteria at month 6. So of the patients that had a response identified by Toronto criteria, meaning if the alkaline phosphatase was less than 1.67 times upper limit of normal, the complete biochemical response at the end of follow-up was noted in about 45% of those patients. So 114 of the 155 met response criteria based on Toronto criteria at month 6. And of those 114, 51 maintained a complete biochemical response at the end of follow-up. The flip of this is quite interesting. Those that did not have a response based on Toronto criteria at month 6 were 41 patients. And interestingly, at the end of follow-up, none of those patients had a complete biochemical response. Hepatic decompensation during follow-up was noted in about 12 patients. So by identifying response based on Toronto criteria at month 6, you can potentially predict the patients that will likely have a complete biochemical response to UDCA therapy or to your therapy at the end of your follow-up period. When evaluating other predictors of biochemical response, you can see that the effect of Toronto response at month 6, complete biochemical response at month 12, and complete response at the end of follow-up, there were variable rates of decompensation or death or transplantation. The only that was significant up here was Toronto response at month 6, leading to lower rates of decompensation during follow-up periods. And if a complete response is achieved at month 12, leading to lower rates of decompensation as well. So predictors of complete biochemical response at the end of therapy included Toronto response at month 6, a complete response at month 12, and if you had cirrhosis at baseline, you had a lower likelihood of achieving a biochemical response at the end of follow-up period. So these are the main predictors that will help identify patients that are likely to have a complete biochemical response to initial therapy of PBC. Another study looked at the seladelpar data for PBC in terms of changes in GLOBE score and transplant-free survival. So just a reminder that both response was a randomized double-blind placebo-controlled phase 3 trial that evaluated seladelpar in patients that were inadequate responders to UDCA or that were intolerant to UDCA. And they compared seladelpar with placebo over a 12-month period, and patients were then able to enroll into a 5-year open-label extension known as the ASSURE study. So the current analysis that was presented at EASL looked at the change in GLOBE score at month 24, and they looked at correspondingly the transplant-free survival. So just a reminder that the GLOBE score is used to predict what the PBC prognosis is and takes several variables into account, including age, alkaline phosphatase, bilirubin, a platelet value, and it can help predict 3, 5-year, 10-year, 15-year transplant-free survival. So this current analysis looks at these scores at 24 months. What's noted really nicely is that at the initiation of seladelpar, which is noted in the blue line here for patients that were treated in the response trial with 10 milligrams of seladelpar, and those that were able to complete the full 24 months of seladelpar, and the orange line up here for those that were able to cross over into the seladelpar arm in the open label extension, is that there's a really nice decline in the GLOBE score early after initiation of seladelpar therapy. And that is significantly different than the GLOBE score that's noted in the placebo arm up here. So the impact of seladelpar on the GLOBE score was predominantly driven by reduction in alkaline phosphatase values, followed by the reduction in total bilirubin values. And then correspondingly, with a decline in the GLOBE score, we're also able to see that the predicted transplant-free survival is also improved and sort of shows this continuous improvement with ongoing therapy of seladelpar compared to the placebo arm. So this graph here with continuous seladelpar treatment shows that if you predict transplant-free survival based on laboratory values prior to treatment, that's noted in the gray line here. When you're started on seladelpar and you receive seladelpar for 1 year or 2 years of therapy, you see that there's a continuous improvement in your transplant-free survival over 15 years, and that's predicted based on the GLOBE score. And that's compared to the placebo arm, where you don't really see that differentiation in the transplant-free survival predictions. So we'll move to a question here. In the response in ASSURE study, compared to placebo, second-line treatment for PBC was associated with a greater decrease in GLOBE score through 24 months of treatment, GLOBE score up to 12 months of treatment only, GLOBE score primarily due to reduction in total bilirubin, or transplant-free survival. Okay, maybe we can move to the answers or the poll responses. Yeah, so GLOBE score through 24 months of treatment is the correct answer up here. There was a continuous improvement in transplant-free survival, but we're getting to really that was determined based on the GLOBE score findings as well. So it's definitely greater in the seladelpar group, but what drives that transplant-free survival improvement is the GLOBE score through 24 months of treatment, and primarily again based on reduction in alkaline phosphatase values.
Before we move on, Dr. Goel, let's just hop back and do post-test number 3. We actually skipped this one, so if we can reverse back to Hep C for a second. I have ideas I can use for implementing new data to optimize HCV care. Let's give a couple seconds here for you to vote, and then we'll bring it back to you, Dr. Goel. All right, thank you for voting, and we'll go back and turn it over to Dr. Goel again.
Okay, thank you. So we'll move on to some additional data that was presented from the ELATIVE study. Reminder again that ELATIVE was a phase 3 trial for second-line therapy using elafibranor versus placebo in persons that had PBC that were inadequate responders to UDCA or intolerant to UDCA. And in the initial ELATIVE trial that was reported, we did know that there was an increased fracture risk at 6% in the population compared to the placebo group that had a 0% fracture risk. So this was a post-hoc analysis that was presented of bone health in persons with PBC that were elafibranor at 1 year of therapy. And you can see up here that there are characteristics in patients that had elafibranor versus placebo were slightly different, and I think worth noting. So similar BMIs, similar means since years of diagnosis, menopausal rates probably pretty similar as well. I think the concomitant use, tobacco use was higher in the elafibranor group. The concomitant medications perhaps point to the degree of bone disease at the start of trial in some of these patients. So bisphosphonate therapy was more common in patients that were in the elafibranor group. Similarly, vitamin D and analogs were more commonly used in the elafibranor group. So the bone mineral density data and bone-related health was evaluated at baseline and at week 52, and there were comparisons that were derived based on patients that had accessible data based on bone density scans. There was also an evaluation of biomarkers that represent bone turnover, including CTX, P1NP, and collagen-based serum biomarkers. And these really just refer to relative turnover of your bones, and there's expected differences if you have osteoporosis versus normal bone health. There were T-scores that were available for a percentage of the patients in each of these arms. So you can see here femoral neck, lumbar spine, total hip. The bone density scores were available in 63 in the elafibranor group, 27 in the placebo group for femoral neck. The lumbar spine was 64 available data points available for elafibranor group versus 26 in the placebo group. And similarly, the biomarkers were available in a variable percentage. What you can see up here in the table is that the percentage of patients that had osteoporosis and osteopenia was higher in the elafibranor group compared to the placebo group. You can see that the femoral neck scores, the lumbar spine scores, and the total hip scores were slightly lower in the elafibranor group compared to placebo group. And you can also see up here that the laboratory values that indicate bone turnover were different between the two groups, perhaps indicative of different degrees of bone health at the entry of the study. There were 7 patients that had fractures in the ELATIVE trial. That had, in 6 of the 7 patients incurred a fracture that was associated with a fall. There was 1 patient that had a foot fracture and day 268, so about week 38, that was not associated with a fall. And the characteristics of this patient are listed up here. She was postmenopausal and had osteopenia, and also had a previous upper limb fracture and vitamin D deficiency. The lumbar spine score declined for this patient between day 4 and day 413. but the total HIP T-score improved during the same time frame. In the table up here, you can see that there were no significant differences in terms of the score, in terms of changes from baseline to the follow-up bone mineral density data that was available. So during the course of the study, there didn't appear to be significant changes to bone health in those that were treated with elafibranor versus those that remained on placebo. So I think interesting data and more to come to see how we monitor our patients that have PBC, and potentially just a reminder that we have to treat the bone disease as well for these patients. Now, looking at PBC and pruritus, there was an interesting analysis that looked at changes in pruritus for patients that had PBC with the pooled results from enhance and response studies. So a reminder again that the enhance and response studies were evaluating seladelpar in patients that were intolerant or incomplete responders to UDCA. In this study, they looked at 126 patients that had moderate to severe itch at baseline and similar itch scores based on other qualitative scales, including NRS, PBC-40 itch domain, and 5D itch at baseline. And what you can see here is at month 1, at month 3, and at month 6, patients that were in the seladelpar group, noted in the blue line, had greater improvements in pruritus, NRS, PBC-40 itch domain, and also an improvement in sleep disturbance compared to placebo. So really, reiterating some of the findings from the response study that were previously published, but with a larger population of patients that had moderate to severe pruritus. And then lastly, we'll move on to the impact of statins on disease progression in patients that had PBC without cirrhosis. So this was a retrospective analysis of 466 patients that did not have cirrhosis and had PBC. 227 patients received statins for greater than 12 months, and they were compared to 229 patients with PBC that had greater than 12 months of follow-up without statin use. So data was collected prospectively, and the follow-up was about 71 months during this period. So as you can see up here, the statin use is indicated in the orange line here, and no statin use is indicated in the blue line up here. And you can see that statin use was associated with a reduced rate of progression to cirrhosis in this group. And the difference was, this should be corrected, was 3.5% in the statin arm versus 9% in those that were not on statin. And the study also evaluated for all-cause mortality differences between these two arms, and then separately looked at liver-related mortality and non-liver-related mortality. And in each of these categories, you can see that there is a difference with a reduced hazard of these outcomes in those patients with PBC that are treated with statins versus in those that are not on statins. So the difference in all-cause mortality was 4% in the statin arm versus 16% in the arm that wasn't on statin. And you can see the liver-related mortality and the non-liver-related mortality was also differential between these two groups. So a few key takeaways from the studies that were presented at EASL. So the first being looking at early assessment of treatment response in patients that have PBC. So in the retrospective study with PBC patients at 2 treatment centers, we saw that looking at treatment response at 6 months was, using the Toronto criteria, was predictive of having a complete biochemical response versus not at your ultimate follow-up period. So really supporting consideration of second-line therapy for those that are not responding to treatment at 6 months. The pooled analysis from the response and assured studies showed that there was improved GLOBE scores up to 24 weeks of treatment, and that predicted improved transplant-free survival for patients with PBC. The pooled response also showed that there was improvements in pruritus for those receiving seladelpar versus placebo. And then we saw that in the ELATIVE post-hoc analysis, that the bone fracture risk of elafibranor was not significantly higher compared to placebo, and a lot of the biomarkers, while patients are on therapy compared to placebo, remained relatively the same. And lastly, in a retrospective analysis, looking at statin use in PBC, we saw that there was reduced rates of progression to cirrhosis, liver-related and all-cause related mortality for those patients that were treated with statins versus those that were not. So I thank you for your attention, and we'll keep the remaining few minutes for questions and answers now.
It's like there's a couple of questions in the chat here. So I'll read them out. Looks like mostly on hepatitis, but does stopping BLV lead to a rebound of HDV RNA?
So in patients who are not completely suppressed, indeed, the majority of patients show an increase in HDV RNA levels, much more frequent than increases in ALT levels. Therefore, the EMA, this is a European approval authority, has a provisional approval to continue with bulevirtide treatment. Clearly, in those who are negative, this negative result maintains in more than half of the patients. This is clearly the good news. But clearly, I suppose that the right thing is to continue bulevirtide as long as the physician has the impression that the patient benefits from it, unless you achieve HDV RNA negativity.
Okay, moving through the question and answer here, there's another one towards Professor Zoism. In your opinion, should nukes be prescribed simultaneously with BLV in cirrhotic patients with hepatitis delta?
This is a difficult question. The correct answer is certainly in those patients who had detectable HBV DNA. These patients should definitely receive a nuke treatment. But in quite a large number of patients, you have undetectable HBV DNA levels and replicating HDV RNA. And here we have a situation that the previous studies with pegylated interferons actually did not show a benefit of adding a nucleotide analog. We had studies published in the New England Journal with adefovir and with tenofovir, and both substitutions of nucleotide analogs did not show a benefit for these patients. Yet in clinical practice, I see the majority of doctors are pretty much afraid that there may be an unmeasurable significant HBV DNA replications ongoing in the liver, and they continue to prescribe the nucleotide analog. And personally, I'm not stopping this if these patients are referred to our center. The data are very limited, but as the nucleotide analogs are generic, the majority of patients and physicians tend to continue with the nucleotide analog despite limited evidence. But definitely the indication is pro using a nucleotide analog if you were able to detect HBV DNA, even at a very low number.
Okay, and Dr. Goel, it looks like the last couple of questions are for your content, asking if they differentiated between statins in the study, and also regarding the ELATE study, talking about the increase of bone damage versus placebo noted during the trial. Oh, and it looks like there are some other questions as well. If you want to scroll through the Q&A,
Yeah.
see which in the last couple of minutes would be most, practice influencing to answer at this point in this
Yeah.
time that we have.
Sure. So I'll answer the questions about statins and PBC first. So I don't believe that the study differentiated between the hydrophilic versus the lipophilic statins, which is I think what the question's getting at, which is interesting to look at. And I agree because the hydrophilic ones potentially more concentrated, more effective in the hepatocytes and more potent lipid lowering versus a lipophilic one. So I think that is an interesting question, but I don't believe the study differentiated between those. And then the other questions about statins is related to the safety of statins in patients that have cirrhosis. So in this specific study that was presented at EASL, there were patients that did not have cirrhosis but had early stage PBC. So this one did not look at whether or not there could be, differential impacts in patients that had cirrhosis and PBC. In general, it has been fairly well described that statins are safe to use in patients that have advanced liver disease and cirrhosis with close monitoring. But specifically in PBC, the practice is that if you have an indication for a statin based on elevated cardiovascular risks, then it should be safe to use and just needs to be monitored. And then there's another question related to statins about the recommendation for a combination of statins with seladelpar, or perhaps the safety of it. So in both the ELATIVE trial that studied elafibranor and the response studies that have looked at seladelpar, there were patients that were on statins in these studies, and the safety is likely there, but it yet has to be demonstrated. In the elafibranor study in ELATIVE, there was a potential, there were patients that did suffer from rhabdomyolysis and acute kidney injury from that in the elafibranor arm, and those patients were on a concomitant statin. So if you are going to start a PPAR in patients that are on a statin already, it is important to just monitor for muscle injury, monitor for rhabdo, and look at the effect of the liver enzymes as well. So that's, I think, gets to the questions about statins in the Q&A. And then I'll briefly touch on the ELATIVE study and what is being asked about the bone damage. So there was a higher percentage of patients in the elafibranor arm of the ELATIVE study that suffered from fractures. That was 6%, and that was compared to 0% in the placebo arm. It wasn't necessarily indicative of greater bone damage, which is part of the rationale for why this post hoc analysis was performed. And what we saw in the abstract that was presented at EASL is that the patients in the elafibranor arm probably had more advanced bone disease. There was a higher proportion of osteoporosis and osteopenia at baseline, and there were more patients that were on therapy for these conditions in the elafibranor arm compared to the placebo arm. And I think, interestingly, what we saw in the post hoc analysis is that if you're in the placebo arm or if you're in the elafibranor arm, the biomarkers for bone turnover and the patients that had available data to be able to compare baseline bone density scans and then follow-up bone density scans closer to week 52, there really wasn't a difference in terms of bone density metrics. So T-scores didn't really change much during the course of the study. So I don't think it's appropriate to say that the elafibranor increased bone damage. It looked like that there wasn't actually a difference in any of the biomarkers that would that would raise suspicion for increased bone damage. And similarly, there wasn't a difference in the bone density scores that were noted at follow-up during the study period. So there was a percentage difference, but remember, they also mentioned in the post hoc analysis that of the 7 patients that did suffer fractures, 6 of the 7 suffered a fracture related to a fall. So not really sure if that is correlated to being on the study, being on the elafibranor itself. I think I answered most of those questions.
Thank you so much. Thank you to our faculty and thank you to our listeners. You can go online for more coverage of the conference. And the survey link is there in order to access the online evaluation form and to obtain your certificate of completion. Thank you for attending today. We hope to see you at future webinars.